leave screen together.
Sir, I'm recording.
You are recording it, huh?
Yes, sir.
Sorry, okay. Then we can start.
Good morning, everyone. Since we have discussed visual fields in detail previously, today will be just an eye opener. We are going to work on some practical aspects only to provide some clarity for interpreting the fields when you see. Okay. I think there are some senior PGs here. They can volunteer. None of the pictures are labeled, but there is a clue in every picture. Okay, you can try interpreting with that. Can anyone explain what this is meaning? Any of the PGs? Please volunteer. It's all simple. Why? Sandhya, Shwapti.
விமலா ஓவரால் பேரா கூப்பிடுங்க ரவுண்ட்ல ரொட்டேஷன்ல.
Sandhya, can you try?
Yes. Ma'am, this is single field analysis of 24-2.
Yes.
So, the fixation target is a central target. Fixation loss, the reliability of the field is good.
Sandhya,
Sir?
I think your laptop as well as your mobile both are simultaneously on.
Yes,
You're getting a lot of echoes. Okay, so you switch the audio of one off.
Hello.
I think she's having some problem with the
Yes.
audio.
Then Shwati.
It is okay.
Okay.
Hello.
Yes.
Yes, Swati.
Sandhya,
Go ahead.
Shwati, anybody?
Yes, ma'am. Am I audible, ma'am?
Yes, you are very clear.
The testing program is Central 24-2 with the Sita standard strategy. The stimulus used here is size 3. The pupillary diameter is not mentioned and the refractive correction was not given. The reliability indices are good with zero fixation losses. Hello.
Yes.
Go ahead.
The raw data shows reduced sensitivity in superior inferior vertical meridian like vertical meridian. The total deviation numerical plot and the pattern deviation numerical plot showing decreased sensitivity in both superior and inferior points. And the glaucoma hemifield test shows outside normal limits with abnormal PSD and mean deviation, but as the refractive correction is not given, feel this chart is not reliable.
Swati,
Yes, ma'am.
do you think this is a glaucoma defect or a
No,
neurological?
sir. No, sir. Then it is and it is an vertical. Yes, it's not a glaucomatous field defect, sir.
See, it's the main aspect.
Okay, okay, sir. Okay, sir.
Yes.
And if it's a new usually the glaucoma fields will respect the horizontal meridians will respect the horizontal meridians. It is not. Hello.
Vimala, you can.
Actually, the refractive correction was given. It has not been mentioned. Okay. That must be the reason, because with this good reliability, the point of using this chart for today is to show that you have to interpret the chart schematically. Okay, starting from one place to the other, we cannot jump on data. You have to start from the top left and gradually go serially and come and finish at the bottom of the right.
Okay.
Okay. That is
Okay,
the
ma'am.
reason for this chat. Okay. It is a single field. What you have to say is it's a single
Single
field
field.
analysis of right eye of a person, the name not shown. It is a central 24-2 test. The person has done the test with a good reliability, and you have to say give only a provisional diagnosis. That's the most important point I want to stress, because with the field we don't come to any conclusion. We are not having any details about the vision of the patient, intraocular pressure, fundus picture, any other history, because this is more suggestive of a neurological field. So without all that, we will not give any particular diagnosis. We can give a differential or a provisional diagnosis. Okay. The points are numbered to show the serial order in which you have to analyze. Okay. The bottommost line, do you know what it is? The bottommost serrated line on the left.
Gaze tracking, ma'am.
Yes. Okay. That is one method for monitoring fixation, a gaze tracker. Okay. Okay, then can we go to the next, and who is ready for the next one?
You call out Vimala, no one is ready.
Uh, Sandhya, I think Shwati is first. This one?
uh, this shows the bracketing strategy.
The purpose?
Ma'am,
The purpose?
uh, we'll start like from where the person is not seeing. From that, we'll reduce the decibels by 4 decibels, and then until the person sees. Then again, once the person sees, we'll increase by 2 decibels. It will cross the threshold twice.
Actually, we have to start from where the person is seeing. If a person is seeing some 30 decibel point, it will reduce by 4. Like it will come to 26. Okay, then it will try 22 in steps of 4. If the person is not seeing, it will step up. Okay, from the seeing area, it will gradually reduce. The point is to assess the threshold at one particular point. Okay, this is an inbuilt software. We are not doing this manual calculations. This happens due to the inbuilt software of the machine. Okay, this we should understand how it arrives to a particular number at one point. Where is the maximum number? Where will be the maximum number of the chart in a normal person?
In fovea, ma'am. Max.
Where in the chart? I mean, will it be in the centermost point?
Center.
Is it in the center, right, left, up, down? Where?
I think the other pages can also volunteer to answer.
Your answer was right, but why are you not sure? The maximum will be in the fovea, right? Huh?
Yes, ma'am.
Your answer is right, but you have to be sure. You should not be having any doubts regarding this one. The maximum
Yes, ma'am.
will be the value of the fovea, which is in the center of the chart.
Yes, ma'am.
Yeah. The least point, where is it?
Blind spot,
Where,
like around them.
where will it be?
It is 15-degree temporal to the.
Is it a circle? It is actually 15 to 20-degree temporal to the fixation point from the center, right?
Yes, ma'am.
It is an oval. In a normal person, it is oval. Vertically, it is a larger one than the horizontal. Okay. All this have some relevance, around 8 vertical, approximately 6 horizontal. All this are relevant because we are going to go down to the charts. Okay.
Yes, ma'am.
Next person for the next chart. What is this?
Select like 2 points above and 2 points below the horizontal.
Sandhya, you are not audible clearly.
Sheetal?
Ma'am,
You can try, Dr. Sheetal. Yes.
Yes, sir. Uh,
Make mistakes. This is a forum. This is a very unofficial forum. You can make mistakes. The idea is to understand what we don't know and get it corrected.
yes,
Right?
sir.
Don't
Yes,
feel
sir.
nervous.
Yes, sir. So there is a 6-degree resolution, 6-degree resolution, and targets are presented closer to the fovea. Um,
Are you talking about the left one or the right one?
Left one, ma'am.
Okay. Any more? Any more?
Um,
Sandhya?
Yes.
I think Dr. Geetu, she can, she's giving her answers. She's typing it down. You can come forward and tell.
There is a difference between the right and the left picture. We had discussed this last time. I'll give you a clue. See where the points are placed. Where is the point located in relation to the vertical and horizontal line?
Resolution, ma'am. Degree of resolution or
No, not the resolution. It is the same.
if it is 6-degree, then it is 30-1, ma'am. 76
Yes.
points
Where
are
do you
there.
see 30-1?
Um, um, then, 10
Is it our preferred mode for testing?
no, ma'am. We prefer 30-2.
Then why?
So,
In most of the chart, the first chart you read 24-2. You will mostly see only the -2. There has to be a reason for that. Why not -1 and why -2?
dash 2 is for picking up only targets closer to fovea, ma'am.
-1 also you have
0-2.
points around the fovea, na?
That too, the points will straddle
Anyone?
ma'am.
Anyone?
Yes,
From 30 dash,
Geetu.
yeah.
Yes, go ahead.
From 30-1, the points lies on the meridian, ma'am. In 30-2, it lies on either side of meridian on all four quadrants. So it
Exactly.
covers the central 6 degrees of resolution will be covered.
60-degree resolution is there in both.
But since it lies on either side of the meridians, ma'am, it will cover more point compared to 30
It
dash.
becomes 3-degree to phobia because when you see the picture in 30-1, there's one point in the center, the next is 6-degree on either side on four
Yes,
diagonals.
ma'am. Yes,
Right.
ma'am.
Whereas in -2 patterns, it is you have 2 points. The difference is 6-degree, but when compared to the line or the fovea, it is only 3-degree far.
Yes, ma'am.
Get more details about the fovea on this -2. That is why that is the preferred mode and why most of the charts will carry this -2.
Okay, ma'am.
Okay.
Okay, ma'am.
And
Okay, ma'am.
on the right, when you see there are four small figures.
Yes,
Okay.
ma'am.
Can you tell me what is the difference? It's actually labeled. We can always test 30-2. Then why do we need a 10-2? The bigger the better, isn't it? When you can get data about 30-degree, why do we need 10-degree? Why do we need 24?
24 degree, it has extra 2 points. We have the
So it's
extra 2 points on the
okay.
field, ma'am.
When you see the 30 degree, you have more extra points. You can see the number of dots. Compared to 24, 30 has more. Then why do we need 24? Why do we need 10 dash 2? Is there some indication? Or we will do it for everybody? Or instead of 30, we can do 10 dash 2 for everybody? Any reason?
Um, when the points are close to fixation, we need a 10 dash to assess whether it involves the macula or whether the macula split.
Okay. Macular pathology and other? Only for macula?
For advanced glaucomatous
Yes.
also we
Yes,
can.
in glaucoma also the recent guidelines is to assess the GCC through OCT and 10-2. Before
Yes.
calling there is no evidence of glaucoma. And in any glaucoma case, we can have more details about the macula. 10-2 not only for macular diseases, also in glaucoma. Okay, it gives a more magnified view of the central area. Why 30-2 and 24-2?
Um, most uh,
We have
most field defects are within in glaucomatous field defects are within the 24-2 range. So and to avoid the patient fatigue, the 24-2 is preferred.
the thing is the number of points tested. Okay, when we do a 30-2 test, the number of points are more, and when we do it for both the eyes, there are too many points that are tested. But studies have shown that the same results can be derived by doing a 24-2 test. The reduced number of points, the patient's cooperation, and the better results. That is why, after many studies, they have derived like instead of 30, 24-2 is equally helpful. And
Okay.
when we want greater details on the central area, we do a 10-2. Okay, that is the reason. The number of points. We are doing so many number of points for both the eyes. This will fatigue any normal person. For this, we have to undergo the test once. Then we will understand how difficult it is to maintain fixation for such a long time. And that is also a reason you have to give a break between the two eyes. And if a person is not doing the test properly on one day, don't repeat on the same day. Better give them a break. You can complete all the other tests on the first day, and you can set this repeat test on another day, which is comfortable for the patient and us. Okay. All we need is patient to get a good test result. Both of us have to devote time and concentrate. We have to ensure that the patient has a good test by comforting them and explaining the test. That is the reason they have come to a conclusion like 24-2 can give us equal details. Then we can reduce from 30 to 24. Number of points will be less, better cooperation and better results. Okay. So we have to choose. We cannot go randomly to a 10-2 test for everybody. Only for those indicated, that will be an additional test. Okay. Can we go to the next chart? Am I clear? Should I repeat?
Yes, ma'am.
Should I repeat?
Clear,
No,
ma'am.
no, no.
Clear.
Go to the next chart.
Right. We saw about the dash 1 and dash 2. This is very simple. Anybody?
First, first image it shows 30-2,
Did you see the number? Number there?
10,
Yes, yes.
10,
It's a 10-degree field. Yes.
10-2, and
Okay.
okay,
The next
the
one.
first image it is the gray scale.
Okay. Okay.
Uh,
And the next one.
Next it is 30-2. No, ma'am, it is 24-2.
Yes, yes. You can see that gap on one side. On the right side, you have some extra 2 points. On the left side, it's not there. So you have to identify that it's a 20-2, right? Uh, Bottom,
It is 24-2C.
yes. The difference,
Extra points are added in the center 10 degrees
okay. The advantage,
to assess the points that are close to fixation.
yes, because that is more, the central part is more important for our vision. So to get better details, instead of going for a 30-2, we get better detail by doing a 24-2C. If you are given all the options and asked which one would you prefer for a person, you have to opt for 24-2C, right? Okay, can we go to the next? Anyone? This is very simple. That is what we have discussed previously.
Grayscale of 24-2 of right and left eye in the first row.
Okay.
It shows complete superior and inferior arcuate defect
Okay.
with visual field index 32% and mean deviation minus 25, which is very severe.
Okay.
Left
Can you tell me what is this GHT?
glaucoma and
Glaucoma MA field test.
What is VFI?
visual field
So visual field index.
Visual?
field index,
Okay. Next. MD?
mean deviation, pattern
And
standard.
standard deviation and pattern standard deviation.
Okay. What is that P meaning? Capital P?
It's probability. It's a P for
Probability? What is that meaning?
Less than 0.5% of the normal people will have
Compared to
normal population, ma'am, less than 0.5 compared to no
age and race matched.
race
Okay.
control.
Standard population. Okay. Matched population. Not general population. It's a matched population. Okay. It shows how much it is deviated from the normal. What is MD and PSD? What is the difference? You can see one has a minus symbol, other doesn't have a symbol. VFI has a percentage. That is what I want you to take in this. Okay. Hmm? Remember that VFI will come with a percentage, MD will come with a symbol. Mostly it is minus. PSD doesn't have a symbol in front. Okay. And GHD will have three connotations. It is either within normal limits, borderline, or outside normal limits. Okay, that is just one sentence. You cannot come to conclusion based on that. You have to do a serial interpretation of each data given in the chart before you come to a conclusion. This outside or within normal limits is not the diagnosis. You cannot ignore interpreting because of this statement. Okay, whatever it is, you have to go to the detail because you know the vision of the patient, IOP, the fundus, all the other tests of the patient. This visual field machine will not know all this. So this is for you to interpret and don't take this for granted. If you see this THD outside or within normal limits, you cannot ignore interpreting all the data as we have seen. Okay, every point is important. This is only the last portion. If you can see the first chart, okay, that is a eighth point. Okay, that you have to look into it at last, not the first one. Don't jump into the right side of the chart before interpreting from the top. Okay, the bottom is, the first is a 24-2, bottom one is
10-2.
10-2 pad.
dash 2.
The
Yes, we see that the points closer to fixation are relatively spared. Where can this happen? Can you give a diagnosis? of something. Give me a diagnosis. Try anything.
Adv-
Huh?
the points are where the points are spared. That was no. Hello.
No, based on this picture, you have got two types of fields of a person. Based on this, can you come to your diagnosis?
Advanced glaucomatous field effects. Yeah, but we have to correlate clinically with the fundus picture.
Yes, you have to say it is only a provisional diagnosis. I cannot diagnose a disease with the chart. Any other DD you have? Can you have something in peripheral retinal dystrophies like this in retinitis pigmentosa?
Rod cone dystrophies and
Retinal dystrophies also can have such sparing of central vision, peripheral vision being affected. Okay, this scenario.
extensive PRP.
Yes. PRP, retinal dystrophies, all. So you have to give a differential diagnosis. Don't come to a conclusion. There is no clue on IOP or vision of this patient. Okay. What is this? This picture has a meaning. What is this?
Glaucoma hemifield test.
It has a meaning. It is trying to imply something.
It compares 5 zones.
What, right and left?
5 zones, superior and inferior, upper field and lower field,
Okay.
which are mirror image zones.
Okay.
So a score is assigned to each zone, like based on the location of the zone.
Based on what? Based on
Location of the zone.
location of? Is it a random plot? If they are giving assigning some zones, they are numbering it. It has a meaning. It has a reason. Okay. They are comparing. Why not right and left? Why are they comparing up and down?
In glaucoma, it is
So is this test only useful for glaucoma patient? What is that actually? What is the what do you term this as?
glaucoma hemifield test.
Yes, that as answer is right. But the reason for assigning
Hemifield test.
numbers, reason for the numbers, separating it as zones. Then we shall go to the next picture. This is the reason. This is. Can you tell me now?
They are giving
It is marked.
more importance to the papillomacular.
Tell me, Sandhya, make a try. It is labeled very much there.
It's
More importance is given to the papillomacular bundle.
Yes. Okay. That is
the
yeah.
picture shows the arrangement of fibers in the that one indicates the papillomacular bundle and the superior arcuate fibers and inferior arcuate fibers.
I want to notice the pattern of the fibers. Okay, on the nasal side there is not much slope. Okay, they make a very short course to the optic disc, whereas on the temporal side both the superior and inferior have to arc around the papillomacular bundle and come to the optic disc. That is the reason that we use the term arcuate scotoma. We don't use the term superior and inferior. We say superior arcuate, inferior arcuate particularly. The term arcuate is used for this reason because the temporal fibers will make a larger arc to come to the optic disc compared to the nasal. And the papillomacular bundle will be confined to the center. And there is one horizontal line called the horizontal raphe. The fibers of the superior don't mix with that of the inferior. It is not jumbled. They go in a characteristic pattern. That is why a horizontal line is drawn in the previous picture, indicating that they are separated. That is why we are comparing the superior and the inferior points, and in particular they are called mirror image points. Mirror image points. The point 1 on the superior, the similar picture on the bottom, 4 top, 4 bottom. So they are called mirror image points on the separated by a horizontal raphe. And glaucoma hemifield test is not used only for glaucoma patient. It can be used for any field testing. For a neurological person also, this is the common 24-2 GHT which we are going to test. If needed, we will go for further testing. Suresh, I think am I right, sir?
Yeah, it is right, but we don't take it into account.
Yes.
Because basically the fact is the sensitivity of both the superior across the horizontal raphe is similar. That is the basic concept. So on either side of the horizontal raphe, the sensitivity of the axons are similar. So they are comparing it across the horizontal raphe to find out.
The typical word is they are mirror image points on the superior and inferior, and GHT is not only for glaucoma. It can be used for any testing. Okay, that is the point I want to show here. And the reason for this is the arrangement of fibers in the retina. Right. What is this picture? Very simple. Any basic textbook, even in a UG book, it will be given.
Given picture shows the Seidel.
They are proper names. First, you have to describe the defect. Describe, because we have used terms like scotoma and depression previously, right? They were differentiated in the previous class. You have to use this first, using these proper names, you have to describe the defect. In the picture A, what is the bigger black solid oval portion?
Blind spot.
Yes, that means it is on the temporal side, right?
Yes,
The
ma'am.
smaller black dots, what can you call them as? What are they called as? They are called paracentral scotoma.
Central defects.
Paracentral scotoma,
Defects,
because they are
scotomas.
absolute solid field. Okay, that means they are paracentral scotomas. Picture B.
Superior arcuate defect, ma'am.
Yes, you understood the meaning for the arcuate right now, right? C.
Superior arcuate defect with Seidel scotoma.
Yes. Okay. So started extending inferior also. 4. Mindy.
Double arcuate scotoma, ring scotoma, ma'am.
Annular scotoma. Anything. Okay. This is typical of glaucoma. It's pairs fixation, and arcuate defects are typical for glaucoma. Okay. Typical, but there are DD for arcuate defects. Okay. But mostly in glaucoma, the central fixation will be spared. Take care of that point. This is one case study. All these charts, I ask you to presume that the reliability parameters are good. Refraction has been done. Okay, all are apostles 31.5 background. Stimulus has been white, and it is capital numeral 3 in all the charts hereafter. I want you to interpret the significant findings. Sheetal, Geetu,
It's not bad.
anybody?
It's bad.
Seidel
Para-
scotoma, ma'am.
Seidels.
Seidel is a proper name. You will not tell that everywhere. Okay. And you don't see whether it is. You have to say there are scotomas in the superior aspect. They are very significant with a very low probability, and there are 3 or more non-edge points. What is that criteria called
Anderson's criteria,
Some
ma'am.
criteria.
for diagnosis of Criteria for diagnosis of?
glaucoma.
Yes, be sure. It's very
Yes,
simple.
ma'am.
Okay.
Oh, yes, ma'am.
Non-edge points. Huh? You have to ensure that it is a non-edge point. This, what type of field is it? 30 or 24?
30, ma'am.
24-2, ma'am.
Yes, it's a 24. You can see the 30 is not filled on the left side, right? Only on the right side it is
Oh,
coming.
yes, yes. Oh, yes, ma'am. Yes.
30 will be a perfect circle. I want you to see that again. Can you see? In the left side, the first picture, 30 will be a complete circle. 24 will
Yes,
not be
ma'am.
like a circle. It will be skewed to one side. Okay.
Okay, ma'am. Okay, ma'am.
And in 24-2, all the points are significant. Okay. All the points which are defective are significant. We cannot ignore some points. Okay. So there are 3 or more significant scotomas. Okay. Significant points which are with a very low probability in a normal person. So they are taken as significant. This one? This also has a proper name. The picture is given beside, you can also give a diagnosis. Sandhya? Keetu? Have you heard of the term nasal step?
Swam.
Yes, this is that nasal step.
Step.
A person has a large cup. His fields are showing nasal step, a perfect division across the horizontal raphe. It is called a Roney's nasal step. Okay. Huh? This is one of the findings in glaucoma. The clue is the bigger cup in this picture. Okay. It is a nasal step because you can see the blind spot on the other side. Okay.
Yeah, ma'am.
This one.
Overview analysis of
Yes, overview.
10 dash
What does the term overview mean? What are they doing here?
they about 16 printouts of single field analysis will be kept without providing any other details.
Okay.
It is not a statistical associated. Not
Any purpose? Why are they doing this?
to assess the progression.
Okay. When we see individual charts, we will not be identifying any early changes. So there is a program to do an overview. Okay, the software has this option. This is actually 10-2 field. This is a overview analysis of 10-2 field of the left eye of the person. The charts is compared from October 1992 to August 1997, around a span of 5 years. Okay, the single eye of that person. What is happening here?
The mean deviation, like, it keeps increasing, um, and there is definite progression.
How much? How is it?
Normal change in mean deviation in normal people is like 0.08 per year,
Yes, yes,
but
yes.
the change here is more than 0.08.
Uh, More. Yeah, it's very significant. From 15, it has come to around 24. Okay. Is this a regular course of a glaucoma person on treatment with us? Is it the field of a person who has been adequately treated,
No,
optimally treated?
no.
Yes, this is not the aim of our treatment. We should halt progression. Okay, for this person's mean deviation has worsened from -15 to -24 around. Okay, over a course of 5 years. For any person, the same 15 will may not remain after 5 years because there is some age-related decrease in a normal population also. Our aim is to minimize it and keep it at the rate of normal progression and not exceed in a glaucoma patient. So when it exceeds that, that means it needs some medical or surgical intervention. Okay, this is not an ideal one. Maybe this person is not compliant, but this is given to give a this picture is brought to show how a overview analysis can be helpful to us. Putting on a single chart makes it easy rather than going and looking for every single chart 6 times. Okay.
Shows the progression analysis, glaucoma progression analysis.
Okay. First, can you see what is the difference between first line and second line? What is happening? First, we will do serially from top. First and second. I want you to watch for this numerical data. Can you see on the top the first quarter? I am comparing the first line and the second line, only the numerical data. You can see on the quadrant on the left, it is -9, -8 in the lower picture. -5 is -4. Okay, you can see 1 decibel change in number. Can you see that? Similarly, when you compare point to point on the right side also, the same is happening. 1 decibel change in number. Can you see that?
Yes.
That is the difference between total and pattern deviation. They are making, they are removing the generalized changes and bringing out the localized changes. That is the meaning of a pattern deviation. Okay, MD and PSD. This is what they are trying to derive. A 1 decibel change has been made to erase the generalized depression, which can happen due to cataract, some refractive error, or any other media change or whatever. But in the bottom picture, there has not been much change. Rarely there and here. In the top two, there is 1 decibel decrease across the whole chart. But in the bottom, there's not much change. So the person may or may not have a generalized change. That is what I want to bring out with this picture. Okay. Are you able to see that numerical change?
Yes.
Okay. There are some software calculations, how much will be subtracted. That is another complex topic. How they are calculating that particular number is a different topic. But I want you to just understand that from the total deviation, some general changes are removed and localized defects are brought out better with a pattern deviation. This is a test done in January 97 and November 98 for a person. Okay. And on comparison, the defects have increased in intensity from the top to the bottom. Okay. This is what I want to derive from this chart. We'll go to the next. Somebody?
Single field analysis of a 62-year-old person
Okay.
of left and right eye.
Mm.
The fixation target is central. Left eye with reliability indices good.
Okay.
The stimulus, the test duration is 3, and the stimulus used is size 3 wide stimulus. pupil diameter is 4 millimeters.
Okay, right.
Refractive correction has been given, and
Okay.
the raw data, in the grayscale, there is a depressed point.
Grayscale, grayscale, what do you see?
Grayscale, there is
Scotoma, is it?
is
What is that?
The blind spot, ma'am.
Yes, that is the physiological blind spot.
Blind spot. It's a blind spot.
Scotoma, it's a physiological blind spot.
but usually it comes
Okay, calm down.
here. Then comes the total deviation numerical plot,
Okay.
and total deviation probability plot, it shows two points in the superior and inferior temporal field.
Okay. The left eye is relatively normal. There are only one or two small changes which we have to watch for in the further testing. Okay, the person has a good visual field index, very small mean and PSD. Okay, we can take it as relatively normal. These small changes we cannot diagnose any disease. Okay, it is not alarming. We can wait. We can do it in the next test. Okay, these are okay. You have to see into the numerical data. There is only a small change in number. It is not a dark solid square. Okay, so it's not an alarming one. This one or two is okay. Come to the right side.
Right eye, the fixation target is central. Fixation loss is there is more fixation loss, so the field is not the report is not reliable.
Okay. So if you did not interpret this top and you went to this GHT directly, it will give an impression like right eye is abnormal, left eye is normal. Can you give me one reason how can this be for a single person? What are the possibilities for a person with this abnormal right eye field and a left eye field? A relatively normal left eye with an abnormal right eye. What may be the reason? Can you explain? I want you to also see at the bottommost line, the gaze tracker. In the left eye, it is it's a very straight line. In the right eye, you can see large deviations from baseline. That means the person has been moving the eye and not fixing properly. Can you see that gaze tracker? Is it visible?
Yes, ma'am.
Yeah, you can see
Yes,
that
ma'am.
most line, compare it to the right and the left eye. The person may not have understood the test in the right eye. Okay, this may be a part of the learning curve. The person has done a better test in the left eye. What you do is better refix one more test on a different day, right? We can just have the test, and when we get a better test with good reliability parameters, we can take the second test as the first one. This should not be used for further future comparisons. When you compare over time, you have to take, like you do it in another 2-3 days, that should be taken as the first test with if it has good reliability parameters and others. Okay, this should be discarded. This should not be taken for future analysis. Okay, that is what I want you to derive from this point. So also view the gaze tracker if it is available. Okay, you can see how the person has fixed well in the left eye and not in the right eye. All upward deviations are movement from the fixation point. What is this?
Regression analysis.
Someone else can attempt, no?
It shows the pattern of visual field index sensitivity decreasing pattern, ma'am, over the year. Like from
in proper terms, you have to say that it is a visual field index chart where the age is plotted against the numerical visual field of that person. What that black square will indicate? What is that? What is this number? So many black squares. How they have arrived at that? First, we should understand what they have plotted, what they have done. Then we have to get an impression from it. The conclusion is the second part. How they have plotted this dark black squares, how would they have arrived at it? Each square is the conclusion. We saw the VFI numbers of each test. Every chart has a value. Na? For this particular person, for that particular eye, they have plotted one square for each test. Maybe that person had 90% in the first test, 85% in the next test, again 92. So you can see the second test came down a little, went again up, and after some time period, they had repeated. So it has gone up and down. So when they tried to put a line across the closest possible to connect the dots, they have arrived at a slope. Can you understand? Each square indicates the VFI value of that test. The first test will be in the left, and gradually they have plotted it over time, the age of the person. Okay, can you understand?
Yes, ma'am.
The first test has started around 56 or 57 years, and they have done till 65 years. So we have to take this person maybe 65 years old when we are interpreting this. Okay, now come to what the chart has to tell us. What it is, what data is giving, it is giving us. What is this slope doing?
Gives the rate of progression.
Rate of progression worsening of disease over the years.
Okay, is it worsening very rapidly or according to the age related pattern?
Worsen
Is it equal to the age related decline, or is it more?
more.
The answer is very much there.
It is more. It is significant.
You have the rate of progression there itself, minus 3% per year. Just now somebody told me it is around 0.8 to 0.9, isn't it? So it is more than 3 times the normal expected age-related decline, isn't so? And the statistical correlation is also being given that it is a significant one. Okay. Okay, now we have imagined that the person is 65 years old. The slope is extending beyond that. What is the reason? What is it trying to do? If he's 65 years, why should they draw something away from 65? We have not done that test yet. This person is today 65 years old. Why are they plotting beyond 65?
It tells how rapidly in progress if the
Um,
progression is in the same rate.
Yes, if it is maintained in the same way, how rapid is it going? And this slope ends at the age of 70, right? It is projecting what will happen to him 5 years later. From his record for the past few years, around 57 to 65, how is it going to proceed if we are not doing anything when he reaches the age of 70? Okay, this is an alarm that we have to do something aggressive about his treatment, right? Do you understand what I mean to say? This is a VFI plot of a person where age is plotted against the VFI index, and it's the rate of progression based on the VFI values of different tests done over time shows a very rapid decreasing slope and the person is likely to lose lot of vision at the age of 70, and it is an alarm for us to intervene. That is the use of this. So this plot cannot be done based on 1 or 2 tests. We need as many number of tests, the better the slope we will have. Okay, an approximate line which can join the maximum number of points will be drawn, and that will be called the VFI slope. Am I understood? Is it okay? Anybody? Sandhya, Shweta, Sheetal.
Progression analysis. This chart shows progression analysis of Sita standard strategy.
Okay.
So the test they are being performed from 2000, 2002 and 2004.
Okay. They have done at an interval of 2 years approx. Okay.
Yes. So in the the mean deviation at the first test is minus 7.8,
Okay.
where it is increasing more in the subsequent tests.
Okay.
And in the probability plot, it shows like there are 2 half-filled triangles and 2 full triangles.
Okay.
It is suggestive of possible progression.
Okay.
And the next test, there are more than 3 full-filled triangles, which is suggestive of likely progression.
Okay. If it is significant in 2 charts, it is called possible, and 3, it is called likely progression. But when you see at the pattern standard deviation, the first one is 5.74, second is 9.49, whereas the third is 8.54. The second and the third are pattern standard deviation is relatively not varying too much, whereas the mean deviation is from 11 to 14. Can you see that?
Yes, ma'am.
So the localized changes are not much significant, but it is some generalized depression has been there from 2002 to 2004. Maybe the person has cataract or something. That also should be taken into account. You should not directly go into the triangles. Okay.
Yes.
So this person mean deviation is definitely showing a gradual decline, whereas the pattern standard deviation for chart 2 and 3 is not showing much variation. Okay. So there may be some other reason for this generalized variation also. After that, you have to go to the probability symbols, that triangle symbols. Okay. When you see the triangle symbols, you have to go to those specific points. How much it has been varying from minus 11, it has come to minus 18. So that localized differentiation is brought up significantly by a solid triangle. When the variation is little, it will be a hollow triangle. And half filled is something in between. Right. So you have to see into every parameter. So we cannot conclude based on this. That is why they say likely. They don't say it is progressed. It has progressed because there's some PSD variation which we have to find the reason. Okay, the PSD is relatively stable. Only the MD has varied more. Can you see that?
Yes, ma'am. Yes, ma'am.
Can we go to the next? What is this? Please try somebody.
The HFA 30-2 of right eye shows
Somebody says 60, somebody 30. Which is right?
It's peripheral field testing, 60-4.
60 dash?
4.
Oh, because it is 30 dash 2, it double the number 60 dash 4, is it? This is actually a peripheral field analysis done for a neurology patient because the neurologist wanted more details on the peripheral field. And for some legal purposes also we can use to find out the field of the person before certifying some medico-legal blindness in retinal dystrophies and all. We can use this peripheral field testing. You can see the center is blank. This is a 30 to 60 degree field, peripheral field. Okay? Can you see the center is blank? So it's a 30 to 60 degree peripheral field test. Okay? The indication can be medical legal or some reason the disease that warrants need for peripheral vision testing. More often neurological diagnosis will need this peripheral test also. Whereas in glaucoma and other things, and macular diseases, we'll be focusing on the center. Okay. It is not 60-4. It is a 30 to 60 degree peripheral field test. Please try. It's a simple one. It's a simple one.
Single field analysis of 30-2 of right and left eye.
Okay.
Left eye showing good with the fixation, central fixation point and good reliability indices.
Okay.
The strategy used is CITA standard with the correction of refractive error given. Pupil diameter 6 mm. The foveal decibel is 34. The grayscale shows left mm, left-sided hemianopia.
Mm. Yes. Okay. Anything more you have to tell? One night has been mentioned like the reliability is a little poor. What are you going to do? Are you going to ignore this test? Can this person have some real difficulty in doing the test? Is it worth taking or ignoring? We cannot take, because you cannot be hard and fast. The person is doing this test for so long. So if it is going to give us some useful information, we should not discard this test. You said left hemianopia, right? Okay. Is that what you wanted to say? Left hemianopia? Doctor?
Left homonymous hemianopia, ma'am.
Yes, homonymous hemianopia. Because left hemianopia is the diagnosis for single eye. This is the chart of both eyes. Okay. So it is either homonymous or heteronymous, which you have to mention. Single left hemianopia is only for single eye that does the diagnosis. Actually, I don't want to ignore this test. The reason being, you see that the fovea is also partly affected for this person. So they can have real difficulty in fixation. Okay, which is because of the disease, not because they didn't understand the test. And it is an absolute scotoma on the left side. So the real difficulty because part of the fovea is affected. Macular splitting is there. Okay. But it gives some useful data and we need not ignore this test. We can take it as a left homonymous hemianopia. Okay. And we can do a test later, not immediately to verify the reliability parameters. It is a useful test. We need not ignore. So we cannot be hard and fast. You should also look into the details. That is why we have to know all the clinical parameters before interpreting this test. This one, similar to the previous. Similar to the previous. Is it a neurological or a glaucoma or a retina field?
It's a neurological field,
Neurological
ma'am.
field.
Because it's the vertical meridian.
Okay. Is it on the nasal or the temporal field in the right eye?
Temporal field, both the temporal fields are being
Okay. Where will the blind spot be usually? Nasal or temporal?
temporal to fixation, ma'am. 15
You
degree
can
temporal.
see the blind spot clearly on the other half, isn't it, in both the pictures?
Yes, ma'am.
That means which field is affected? Which is complete scotoma? Is it nasal or temporal? Here, actually, the nasal field of the right eye and the nasal field of the left eye is affected. This is a binasal hemianopia.
Hemianopia.
Okay. Is it homonymous?
So,
In one eye, it is the right side, one eye, it is the left side. So it is not, you can compare it to the previous picture. Here, left eye in both eye, left side in both eyes, right? That is why it is called homonymous. Okay. Here, it is on the right side in one eye, left side in the other eye. So it is heteronymous. Okay, it is a binasal, otherwise binasal hemianopia, right? Reliability parameters are not very good, but leave it. But I want to take the, I want you to take this message. If it is on the same side, it is homonymous hemianopia. Though the reliability may not be good for this chart, it is actually giving useful data to us. Here it is binasal. Okay. And the other thing have to be done clinically correlated. This is a very rare field defect. Actually, I put it for you to identify. Binasal hemianopia is a rare defect. There are some DD for it, but they are all rare causes. What is this? Anyone? Have you not seen this in this shape?
Octopus.
Yes, yes. Instead of the grayscale, here is a color-coded mapping of the field, right? I wanted to understand from this that you have to understand the machine you are using. Every machine has a different pattern. They have different softwares. The printout will be different. So you have to understand your machine, the possibilities, how a single field will be, how an overview will be. First, you have to understand the machine before jumping into diagnosis. For that, you have to look into some normal fields, some simple fields before jumping into diagnosis. The first thing is understand our machine. And I request all of you to do a field test for yourself to know how it will be, what will be the patient's experience, and why it is difficult for the patient, for everyone to do it. Okay, I request all of you to undergo the test once. Please ask your co-PG to do the test for you. This is labeled. Can anyone tell me what is this?
This field pattern shows 120-2 of neurofields.
Esterman visual field for binocular visual field testing.
Yes, yes. This is binocular visual.
Should
This is done for the same person. Why two different one, and what is that SAP, VRVF? Anybody? What is SAP? We are close to the finish line. Faster. Do it. Simple. Just first explain SAP. Standard automated perimetry. That's all. Standard. That means they have used a white on white perimeter to do this binocular field testing. Just this is a standard one, SAP, right? Okay. Any clue what is VRVF? In conferences, must have seen the virtual reality headsets to do visual field. Have you seen? Outside the conferences, they will be having headsets. They may ask you to undergo an experience of virtual reality to do field tests. Have you seen?
Yes, ma'am.
Actually, some big institutions are using this for screening purpose during camps. Okay. But in camp settings, you don't have all the details to make a diagnosis. You can use it for screening purpose. If they have an abnormal one, you can ask them to come to the hospital for further testing. If it is a normal one, you can reassure and not give them an appointment for further testing in the hospital. That is the only difference this virtual reality can make. We cannot come to a diagnosis in a camp setting or screening. Okay. This is a VR VFS virtual reality visual field. This SAP is a standardized one. This one? What is this top and bottom? Just tell me that instead of the finding. Just what is the top and what is the bottom?
HFA.
HFA 30 dash.
Okay.
OCT analysis.
With OCT RNFL combined, ma'am.
Okay. What is this called? This is called structure function correlation. Okay. This is done for both the eyes. We have both the eyes together, the fields of both the eyes. Okay. The person has done a relatively good test, a reliable one. We are comparing their field with the OCT findings. This is called structure function correlation. This gives us a much better impression before diagnosing. Okay. And you can compare both the eyes, field and structure, both. Right. Is it okay?
Okay,
This
ma'am.
is called a Hood report in some machines, but it is basically structure function correlation. This software is available in the recent all machines. Instead of, so we have graduated from a single field analysis to an overview analysis, the different findings, and now to structure function correlation. Stepwise, we have progressed from single field to this. Here they are going to compare the green and red areas in the bottom, the curves with the field effect, whether it is corresponding to the field effect, the thickness to the field effect. This one. Anyone?
Enlargement of blinds.
Okay. Any other person? Any other?
Or
The last person. Last person. What did you say? The last person said something. Yes, it's a normal visual field. These arrows are to mislead you. It's actually a normal blind spot. When you so look at the size of the blind spot, it is less than 10 degree, which is normal, purposefully pointed arrows. So when you see the bigger picture, don't miss the normal field. You can know anything about the diagnosis, but uh, don't watch for all the abnormal findings. It can be a normal field also. So I like to conclude saying you have to be systematic in looking for all the points, and this is a perfectly normal person's field. Okay, this one we are not going to discuss this in detail, but what are these lines? There is a term.
Isop
Yes, yes, same. Tell me.
isopter.
What are they? Anything you know about that term? Isopter? They are not symmetric circles. Yes. Please tell the what.
Isopters are the lines which connect the points with equal retinal sensitivity, ma'am.
Okay. What this picture is made from which perimeter? Humphrey or octopus?
Goldman.
Yes. Is it static or kinetic?
Kinetic.
Yes, Goldman kinetic perimeter. Okay, you just take this isopters. This is the term not used for a static perimetry. It is the term used for kinetic perimetry, where the lines will be showing isopters connecting points of equal sensitivity. Interpretation of this Goldman perimeter is a totally different one. It's a big topic in itself. We are not doing this regularly, but we used to do tangent screen method and all. But I want to just give an idea that isopters are not used the terms in static. It is used in kinetic perimeter. Okay. End of my slideshow, sir.
Thank you, Vimala.
I,
That was quite an exhaustive. Madam has almost tried to give you a overview. Now I don't know how much of you have slipped through it or really listened. There is a quick quiz for you now, waiting for you. Vimala, you can stop sharing.
yes, sir. Yes, sir.
Okay, don't need to get tired. It is more like a quick quiz. How do I present this? How do I start presenting this? Hello,
Slide.
right click,
Slide shows
slide show.
top. F5.
File,
F5.
F5. It's not happening. It's not happening. Somehow it is not happening. I don't know how to go about.
You can ask the question, sir.
Ah, no, I wanted to show something. Okay, we'll do that. So the questions are like, what are the components of a Goldman target? So we have talked about size 3, size 1, size 2. Can anyone tell me what are the components?
Components are size, intensity, and stimulus.
Okay, that is the basic thing. But when you see a Goldman target, if you are seeing in a Humphrey test, they are putting as Roman letter 1, Roman letter 2, right? So if you are looking at a Goldman's target, what will you see? What are the parameters written? Anyone?
A Roman letter, an Arabic numeral, and a small small letter.
Yes. Can you tell me what is the meaning of all those things?
So Roman, it gives the size of the target. The Arabic,
Are you able to see my screen now?
yes, sir.
Yes, sir.
Oh. Okay. So what I will do, I will just give you the answers also because it is also becoming late. So we have to know that Goldman's target has, like you told, a Roman numeral, Arabic numerals, and numbers. Okay. When Roman numeral indicates the size of the target. The biggest is 64 millimeters squared if you are talking in terms of area, and the smallest is 1/16. Okay. The Arabic numerals indicate a 5 decibel change. So if suppose I write 1, Roman numeral 1, and Arabic numeral 1 means it is that and Arabic numeral 4 means the difference is 5 decibel between each. Okay. And subset of this is A to E. So 1A means it is 1 decibel and 1B means it is 1 decibel brighter than 1A. Are you understanding?
Yes, sir.
I'm not hearing anything.
Yes, sir.
Yeah. And again, the speed of movement of the target for a kinetic perimetry is 2 to 3 degrees per second. Why I am putting this is, these are questions which can be asked after giving you a perimetry chart. Okay. So what is thresholding? Madam just now explained. So can you tell me what is thresholding? Anyone?
It is the
Ability to detect a
minimum.
stimulus, sir.
What?
Ability to detect a stimulus.
No, ability to detect a stimulus is okay. What is thresholding? What are we trying to see?
It is the minimum
Minimum
intensity.
intensity the
Ability to see the
patient can
dimmest
see.
point, sir.
1%? What is
Uh,
it?
Sir, ability to see the dimmest point.
No, we want exactly dimmest point that point in the retina is able to perceive.
Yes, sir.
That is more important. That point we are trying to, what exactly are we trying to do is quantify. See, ability to see a stimulus, yes, but how much or how bright or how dull stimulus are you able to see? that to quantify that, we have to do what is known as a thresholding, which madam explained, like 4 decibels slowly it will decrease, and again 2 decibel increase in the brightness. Okay, that is known as bracketing, and this is known as thresholding. Okay, this is what basically they are trying to do. So many of you would have heard CETA, CETA standard, CETA fast. So what is CETA faster? Interrupt silence. So basically they have made all these modifications to a CETA fast. See, initially I told you, just now I told you what is thresholding. So instead of going and trying to find out the threshold in each place, what they are doing is they are straight away starting from 25 decibels. Okay, and trying to find out whether you are able to see. They'll do this in 4 primary points. Okay. And if you see the thresholding, if you see the previous thing, it is going twice. Are you able to see 4 decibel, 4 decibel? It is crossing the threshold, again going back. Okay, in the faster they are going to do it only. The staircase reversal is done only once. Okay, and the normal points, that is the normal decibel from where to start. They take it from the standard standard for CETA fast normal values. No, they use that as the baseline, and from there they start the CETA faster. The third thing is, the fourth thing is blind spots. Normally, when you do a CETA fast or a CETA standard, the blind spots are repeatedly confirmed whether it is being fixation is okay or not. Now they do away with the blind spots. Instead, what they do with the gaze tracker. They give more importance to the gaze tracker, and the Hagel-Krakow method is not given more importance. And one more thing is this false negative catch trials. Every time the machine tries to find out whether you are trigger happy or not, those catch tests are no longer performed in a CETA faster. And finally, whenever the person doesn't respond, there is a 300 millisecond delay which is given so that the bleaching happens and the patient starts responding. That is now shortened. All these changes are made for CETA to become CETA faster. So are you able to see these raw values? There are certain values where there are 2 values. Are you able to see?
Short,
So what is the importance of these brackets? Anyone?
short-term fluctuation.
See, basically these brackets, these are places where it has been tested twice. Okay, so why is it being done? Why is a spot being tested twice? This is normally done only when you do a full threshold. You will not see these brackets and these values in a regular CETA fast or faster or things like that. We will do only in a full threshold. That is to see or calculate short-term fluctuation. Have you heard of short-term fluctuation? Anyone? What is short-term fluctuation?
Intra-test variability, sir.
Intra-test, very good, very good. It is a intra-test variability. So how do you see what is the variability even while doing the test? That is what this is. So to find while I am doing the test, if I show the same point again, will there be a variation? That is the meaning of that, intra-test. So that is what they're actually doing. All these fixed points, what they will do, they'll test it twice. And if there is a variation, they will write it in the brackets. Okay. But this is just the raw value. Now, how are they arriving at the short-term fluctuation? That is one value, If you see the printout, there will be one value, SF, short-term fluctuation. So how do they arrive at that value? So this is how they arrive at the value. Let's say now one point they tested first, it was 30. Again they tested, it was 36. Okay, so one will be in 30 and another they will write 36 in brackets. So what they do is they take a mean of these two values. For example, 30 and 36, the mean is 33. Correct. Now they subtract this mean from the first value and they subtract the mean from the second value, and they take the square of this. For example, 30 minus 33 is minus 3, square is 9. Again, 36 minus 33, square is 9. So the sum of this is 18. This is known as the variance. The mean of all the variance is taken, and the square root of this is what gives us the short-term fluctuation. I just wanted you to know what exactly is happening. Okay, you don't need to know this mathematics, but this is how it happens. So a value of less than 2 decibel, that means there is a consistent performance. Anything higher means there is a patient is not attentive, because even during the test there is more than 2 decibel of fluctuation. Understood? That is how we have to take. So what do you call a long-term fluctuation? Anyone? Long-term fluctuation is inter-test variability. This is intra-test. During the test, if there is a variation, it is known as short-term fluctuation, and long-term fluctuation is inter-test, between two tests. Okay. Now, anyone, what is the minimum and the maximum stimulus in a HFA? Any of these questions, anyone able to get through? You can tell me.
Max 10,000 apostles.
10,000
Apostles.
apostles. Okay. Background?
31.
31.5 apostles.
Okay. Duration? So normally it is better to tell not in apostles when they ask for maximum minimum. If you tell it in decibel. Okay. Apostles is a relative. What is 10,000 apostles in octopus is different in Humphrey. Okay. You tell it in decibels, better. But still it is correct. Background, yes, correct. Duration of presenting stimulus is 200 milliseconds. And this we have to know how many points. 30-2, they test 76 points, and 24-2, they test 54 points. And what is the degree of separation? Already you have repeated. In 30-2 it is 6 degrees, and in 10-2 it is 2 degrees and 68 points. This madam told. I think everyone will be knowing this. What is this? Why silent? Esterman's binocular test. Yes. So what are all the possible outputs that a glaucoma hemifield test can give? This also madam told. She explained also.
Outside normal limits, borderline,
Very
and
good.
within normal limits, sir.
Yes. So what is the meaning of those? See, when, for example, we are comparing 1A and 1B, 2A and 2B, something like that. No, if one zone pair is abnormal and it is 1% only, it can be normal. That when such a change happens, it is known as outside normal limits. Okay. Whereas if the difference is fewer than 3%, we call it as borderline. And if it is across multiple things, we call it as generalized depression. Everything is normal, then we call it as within normal limits. Okay. I'm just going fast because I think all of you must be tired, madam. This anyway, she has told you what to see and what not to see. See, normally the take-home point for this is, whenever you have a visual field, always use the disc picture, or if you already seen the disc, examine the disc. Always compare with the clinical thing with the automated perimeter. Don't come to a conclusion with just the perimeter alone. Here, yes, it is comparable. You have a OCT. OCT is showing a inferior RNFL loss, and comparable to that, there is a superior field effect. Okay, this is just to drive home the point that always compare with one more thing. Just don't independently take the perimeter printout fully. What is this? Again, a repeat.
24-2C.
24-2C. How
C.
many points are tested? Additionally, ten new points are tested. Okay, the regular 24-2 is done, and within 10 new points are tested within the 10 degrees. That we must know. Okay. What is this? Anyone?
Fixation
Fixation
I didn't
target.
get you. Yes, fixation target. So what is the first one? Okay, I'll run through it. See, the first one is the for central fixation. Normally, what we do, okay. Suppose a person has a central scrotum and actually he's not able to see this. Then we use what is known as a big diamond. Are you able to appreciate this? The big yellow square that is known as a big diamond, large diamond.
Okay.
That is used when there is a, because if there is a central scotoma, still the large diamond they'll be able to see. So that is used as the fixation target. To see the foveal threshold, we use the small diamond, that is the C. And sometimes we need to test only the superior fields. Okay, there are certain specialty tests where we want to do only the superior test. Then we ask them to see the inferior fixation point. Okay, so there are, in the fixation itself, there is one central fixation, large diamond, small diamond, and for inferior fixation. Okay. Now here is a case where you have done a 24-2. The perimeter is saying nothing is there, no detail, no data is there. Now suppose you have such a person, what do? We just tell them and there is nothing, you are not able to see anything, or do we go ahead and do something else? Anyone? We go ahead and do a 10-2. Okay, to see if there is at least some amount of central vision present. Okay, before writing him off saying that nothing can be done for you. Okay, so the same person we have done a 10-2 and there is some amount of central field which he can manage his regular activities. Okay, so what is this? Yes, I didn't get you. Anyone? This is a kinetic perimetry. Madam told you, no? I saw her so many things she was telling. This is a kinetic perimetry. But what is special about this? Can a kinetic perimetry be done with a Humphrey? Am I audible or?
Yes.
Very much audible.
Yes means
You are-
audible. But a kinetic perimetry done with Humphrey, not audible.
Selective.
Select. See, kinetic perimetry, the newer Humphrey perimeters allow us to do even kinetic perimetry, and this is a printout of a kinetic perimetry done with a Humphrey. Okay. So in future, someone asks, can you do a kinetic perimetry with Humphrey? Yes, it is possible. We have to say, okay, we must not say, no, it is a static perimeter. Now what is this? Why is there so much difference between the total deviation and pattern deviation?
Generalized reduction of sensitivity due to the media changes or media opacity.
So
Reflective error.
could be media changes leading to, and pattern deviation has eliminated all those, and so you are having a literally normal field. Okay, what is this?
White scotomas due to excessive eye falls.
See, normally, what do we expect? We expect the total deviation to be having more scotomas compared to a pattern deviation, right? Whenever the reverse happens, that means we are dealing with a trigger happy patient who is either not fixing properly or is keeping on pressing. Okay, this, what is this?
Gaze tracking.
Gaze tracking, very good. What are the upper deviation? What does that suggest? What does the lower deviation suggest? See, whenever there is an upper deviation, that means the patient is not fixing, he is moving his eyes. The lower deviation happens whenever he is blinking. So whenever you are looking at the gaze tracker and you see more of lower deviation, don't ignore that. It simply means he is blinking. Okay. Whereas if you have a frequent these upper deviation, that means it is not a reliable. There is very large amount of fixation losses. Okay. So this is just to show you the importance of VFI. See, if you see, like Madam told, no, all the parameters, if you see, the mean deviation is just 0.69. So we must be happy with that value, right? It is very low mean deviation. But look at what the VFI is showing. Almost 13% decrease. Why is that? Can anyone explain why so much decrease in the VFI? Anyone? Sandhya?
Sir, center is involved.
See, the
Points.
VFI gives more weightage to the center points. Okay, whereas the mean, it's a mean. So overall, if you see, there are very few deep scotomas or absolute scotomas. So mean deviation is not that much affected. Whereas since these absolute scotomas are towards the fixation, the VFI is showing such a huge change. Okay, so that is why not every time we have to just look at the mean deviation and say, okay, it is very less, so it is good. No, we have to also look into the VFI, because it actually shows how much of, because see, this person is just having a few scotomas, but his day-to-day life would be really troublesome because he's lost his central vision. Okay. And finally, whenever you see a printout like this, it need not necessarily be because of glaucoma. Always look at other the fundus picture or OCT to see if there are other illnesses which are producing a similar picture. This is due to multiple optic nerve head drusen. Okay, and this is just an overview that how to go about. So that brings us to the end of this session. I request all PGs to participate more actively. Sheetal, Geetu, they don't want to let us hear their voices. Bhavya and all, they are just typing. They are not answering. Why? Okay. So in future, I would expect all of you to actively, because this we are on a Sunday, we are taking time just to help you improve your knowledge. So as long as you don't actively participate, you will not know where you stand in the group, right? So in future, I will advise all of you to come. Okay, that's nothing wrong in making mistakes. This is the forum. We are not judging you. Okay, you just have to know what is your capability, where you stand in this group, so that you can improve upon yourself. Okay, I think that brings us to the end. Thank you, Vimala, once again.
Thank you,
And
sir.
thanks everyone for
Sir,
sparing the Sunday.
please
Yes.
share the slides in the group, sir.
Yeah. I am. What I will do, I will see whether this whole thing has been recorded. If possible, I will even share this video also. Okay.
Yes, sir. Yes, sir. Yes, sir. I
Okay.
can also share.
Thank you, everyone. Thank you. Yeah.
Thank you,
Bye.
everyone. Thank you.
Thank you, ma'am. Thank you.